My name is Lori. I work for an insurance carrier in the Midwest. My technology presentation focuses on heart failure clinical outcomes in a non-traditional healthcare model. Heart failure rates continue to rise in the United States. It is the #1 reason people over the age of 65 are admitted to the hospital, with greater than 1 million admissions in the United States each year. The rate of heart failure continues to grow in those patients under age 65 also, growing by 6% from 2000 to 2010 to 29% of new diagnoses, and the majority of these individuals are discharged to home. Today, deterioration and readmission rates are attributed to low health literacy in even younger populations. These patients are more likely to die within just a few years of hospitalization due to the complicated nature of heart failure, with a 50% mortality rate within 5 years of initial diagnosis. Multiple medications, close weight monitoring, nutrition monitoring, and liquid limitations are often just too overwhelming for patients to do on their own. The target heart failure population for participation consists of health plan members under age 65 who are not part of a self-funded plan or other plan with self-imposed limitations. There are also exclusions to federal employees and members of federally funded healthcare plans due to government and IRS guidelines. These selected individuals will have been recently diagnosed during a hospitalization or have had a recent worsening of their condition resulting in hospitalization, or have received a high-risk referral from their primary care, cardiology, or pulmonology physician for participation in our program. These individuals are proactively selected and approached by the insurance plan. The current practice of healthcare plans providing a free benefit of remote health monitoring services to patients is relatively non-existent. The disparate, disjointed healthcare that patients receive is fully felt by the patient, physician, hospital system, and payer, with each thinking the other is to blame, while the patient just continues to decline. Patients faced with so many decisions are making incorrect and reactionary choices to their health. From their homes to unanswered physician calls to 911 to confusing hospital discharges with mountains of unrecognizable paperwork, and back home again, patients feel unable or unconfident to turn toward education about their health or a stronger physician-patient relationship, which could make them better. This program is a collaboration on behalf of members with high-risk heart failure to engage in high-quality home monitoring as a means of early identification of illness and to improve intervention opportunities. This program links the DME vendor, Honeywell, Home Health Monitoring Agency of VNA, insurance plan clinicians, and primary care providers together on a daily basis to intervene for our members. Disease-specific questions with branching logic, biometric data collection, and nurse-to-patient interaction all promote enhanced education, prevention, and physician partnership. Wireless data collection and monitoring that is visible by multiple agencies simultaneously via live stream monitoring technology, patient-to-nurse video conferencing capabilities through the Genesis Touch device, and the bilingual device choices all give this device the adaptability needed to be successful in many home environments. Finally, collecting all of this information through the live stream monitoring system allows simultaneous documentation and communication between the home health agency and the health plan, who can coordinate additional outreach to the physician partners for same-day interventions. Reporting capabilities allow the health plan clinicians to partner with providers for an immediate office visit, reporting needs, or proactive monthly reporting on a well-controlled chronic condition in an effort to improve continuity of care. The administrative cost of the program is approximately $434,000 for 200 members installed over the first 9 weeks of 2016 and monitored for the remainder of the calendar year. The potential savings of the program is based on historical admission expense of $6,900 to $10,000 per 2-day hospitalization. This equates to $1.4 to $2 million in hospitalizations for only 200 people. Extrapolating the administrative cost versus potential hospitalization savings, if the program were able to connect patients with providers early enough to prevent confinement, there is a $1 to $1.6 million potentially saved. All of this is net neutral to the member, who has no cost-sharing responsibility in the program. Programmatic implementation requires vendor relationship management, physician notification and program buy-in, patient selection criteria to meet all participation requirements, and successful and clinically competent 24/7 monitoring for proactive interventions, establishing trust with patients for full participation, and finally, physician availability is key to turning patient clinical identification into interventions and outcomes. A new policy was developed for oversight of this program. Components of this policy and procedure include the program's purpose and qualifications, specific referral criteria and instructions for those using the policy daily, member family requirements for participation to ensure all components are applied consistently among patients, installation and monitoring instructions for daily use, how we will co-monitor with our vendor partners for patient data oversight, discontinuation criteria, and service level agreements between the vendor, the plan, and physician offices. The efficacy of this project is unknown at this point. It is a small pilot project covering only a subset of heart failure patients in one local plan. If clinical outcomes measurement of the pilot indicate cost avoidance and high participation, program enhancements could be made. Limiting factors would include having to change vendors because the local vendor doesn't have national capabilities, and the administrative, contractual, installation, monitoring, and physician relationship burden of a large program, which may be prohibitive. The marketability of a similar collaborative program between vendors, physicians, and insurance plans is high. All parties are seeking to utilize technology to engage a younger population to improve outcomes and lower costs. This pilot is a first opportunity for our plan's disease management department to tap into assistive technology for chronic members as the department's function and future are re-envisioned to meet the needs of tomorrow's patients and also show cost savings value to health plans.